Welcome back to another episode of the Nursing Now podcast. My name is Janelle McSpiggin, and I am here with the lovely Marie Peppers. I'm doubly excited because Marie is an incredibly knowledgeable LPN, and I haven't been graced with an LPN yet on this show, so I'm really excited to highlight her experience through that. And she also helps nurses enter the remote realm, so we're going to have a lot to talk about. Marie, thank you so much for joining me.
Oh, thank you. And I'm so glad I'm the first LPN that you get to interview.
I
And I
know.
have a lot of other very successful and interesting LPNs I can send your way.
Oh my gosh, please, please do. I want to highlight a ton of LPNs on here. Such a valuable portion of the nursing community. So can you tell my listeners a little bit more about who you are and what you do?
Okay, I'm Marie Peppers, as she said, LPN. I have been an LPN about 37, almost 37 years. I went to an old-fashioned school of nursing in Boston. And that's when you'd be in the classroom for 1 week, just learning a little bit. And then they threw us all into the hospital. So I had just hands-on the whole year. The LPN program back then was 1 year, all hands-on. It went through the whole year, no summers off, nothing like that. So I did that. And, flash forward all these years later, I've done a little of everything. And what I want to say to the nurses, LPNs, RNs, nurse practitioners, nursing students, is that as an LPN or as a nurse, I use the proximity principle to work my way into different areas and work my way up to what I'm doing now. And I didn't know that was a principle. The proximity principle is when you want a job or you want to get into different areas, you need to proximate yourself or associate yourself with other people that have the similar interests as you or that are in the area that you might want to get into. So even when I was a brand new LPN, I really wanted to get into pediatrics, med-surg pediatrics. I was in med-surg. Well, there was no such thing really as LPNs being in Massachusetts, being in pediatrics med-surg. So I used to, on my lunch hour, always go over to the peds unit and kind of hang around and, just talk to the nurses. That's proximity principle. LPNs normally don't get into those certain sections. I wanted that. So eventually, because of the relationships that I made, I was able to get into that area and many other things that I've done as a LPN. That's one of the big things I want to say is that if you try to surround yourself with people that inspire you, that you connect to them. LinkedIn is an amazing place to connect to. So throughout my years, I've done all kinds of different things as an LPN. Never wanted to be an RN. I thought about it a few times, but I was happy with what I was doing as an LPN. And I even got into some case management, home health. I worked with the visiting nurses. I mean, I actually did home health where I was seeing the patients, doing wound care and various things, visiting one patient to the next. I was doing home health on the weekends, hospice. I even did some supervisory work as an LPN. Of course, there was always an RN, over me. Anyway, fast forward to now, I am still an LPN. And prior to COVID, about 3 years prior to COVID, I got into a lucky opportunity. It was a doctor that wanted to start the remote nursing program for his patients.
I just wanted to say thank you for bringing up
Okay.
the history of nursing and the strong role of LPNs, and that you're happy in your current role and you never wanted to pivot to another role. I think that there's so much importance in being happy where you are with your current credentials.
Yeah. Well, I have said, to some of the RNs that were my charge nurses, I have said, I'm happy as an LPN and I don't want to be a charge nurse because I don't want to be responsible for anyone else but myself. My patients, of course, when I'm on med surg or wherever I was always under the direction of an RN or a doctor. But, when I'm the LPN and I'm not charge nurse or anything like that, I'm responsible for myself, my patients, and I really enjoyed that, enjoyed not being responsible for other nurses and then their patients. And so, especially many times RNs are, responsible for everybody. So that's one of the reasons why I just really loved my role in what I was doing. And I just didn't want to ever get into any of the supervisory stuff. But anyway, yes, I was at the hospital, and nurses are always looking around to see what's out there, what's better, like I really love my hospital job, but we are always looking to see, okay, so who's doing what and what's what. And it wasn't like I was ever in my whole life, I was never like I was always looking for money, money, money. I was looking for opportunity and what's different. And just like I said, taking your interests and then attaching them and associating yourself with other people, getting to know people, rooting them along the way, becoming friendly with them, whether it be on Facebook or on LinkedIn. I recommend LinkedIn because it's really a good place for nurses, especially if you want to, go further in your career. LinkedIn's definitely the place to be. So long story short, I did take on a part-time position for a doctor that was starting the Medicare Case Care Manager program that came out in 2015. This was 2017 that I took this position, and he handed me the software for the remote patient monitoring and transitional care. And then he handed me the Athena healthcare software, and he just handed me this computer software and said, learn it. And Athena had a little bit of educational programs on their system. So I learned the Athena computer system. I'm not a computer person. And then I learned the Thorough Care system. The president of Thorough Care back then had no real training for what he was teaching me. And so he taught me himself. So I enjoyed my job. I worked from home. I was doing kind of care case management from home. So in between the visit with the patient at the doctor's office and then the patient goes home, all those things that kind of fall through, all of a sudden they're not picking up their medicine. Oh, the MRI that was ordered didn't happen. Oh, the patient didn't have transportation to X, Y, and Z. So my job was care coordination, care management, taking care of those gaps. SDOH. If you don't know what SDOH is, you got to know it. SDOH is social determinants of health. It is the key word, SDOH, the key word for 2024 and into 2025. But nurses have done SDOH forever. SDOH is making sure your patient could pick up their medicine or it's delivered, making sure that does your patient have food? Do they have a roof over their head? Do they have, are they seeing the other doctors that they were supposed to see, transportation, just the basics, social determinants of health. So I did a little of all that, enjoyed it. Long story short, the nurses at the hospital begged me to write a program on how they could do remote nursing. And I said, well, I don't want to do that. I don't want to write a program. I don't do that kind of stuff. And they said, please. So for 6 months on and off, they begged me. They said they wanted to do what I did. And this was, so new back then. Anyway, I wrote the program and eventually they came. And that was my first course. And then I've written many other programs since then. So I know I could talk for hours. So I know we want to condense all this.
No, I love that. I love that. I think it's so important for nurses who are still at the bedside to see how someone who has successfully transitioned away from the bedside has created that like hopscotch effect. So thank you for sharing.
Yeah, I had no intention to ever really leaving because I really liked my patients. I liked working with. I mean, Sometimes it was hard at the hospital or in the nursing homes or in home health. Sometimes you have too many patients, or something's going on. But the majority of the time, I did really enjoy being a nurse. I enjoyed my patients. Most of the time, I enjoyed the other nurses I worked with. Of course, there's always going to be a few that you don't like, and you got to try to get along. And there's always going to be a few that are cutthroat. And as you get older, you eventually learn to let some of that stuff just kind of roll off your shoulders. It's not easy working with I used to say a whole bunch of hens, ladies. And of course, we have gentlemen that work with us too. Many of us nurses really enjoy when there's a male nurse on the floor. It kind of breaks up everybody. So, the majority of my time I enjoyed being a bedside nurse, or home health nurse, or whatever. This was a kind of a fluke. And I all of a sudden realized that I could still be a nurse and enjoy it and not touch the patients or even see them. Now, some remote nurses see the patients on the video, but I was just doing telephone. And I realized, wow, it's a whole new nursing skill to be able to help a person when you cannot touch them. You cannot really see them. You cannot smell them. Nurses use a sense of smell, even though we don't particularly want to smell the bad smells. You can smell gangrene before you walk into that room of the patient's room. Diabetic, you can smell the diabetic sweetness sometimes down the hallway. So we use our eyes, we listen, so, on video or on the phone, it's a little bit different, but I realized, hey, I really like this. Eventually I have a lot of my nurses. I have almost 11,000 that have gone through my courses in the past 5 years. Nurse practitioners, doctor, nurse practitioner, a few doctors, MSNs, BSNs, ASNs, diploma RNs, and LPNs and LVNs. So a variety of everyone. Do have a lot of nurse practitioners that are a little bit burnt out from being nurse practitioners, and they want to now work as RNs again remotely. Some of them will work remotely as an NP, but a lot of them want to do utilization review or care or case management remotely and use their RN again and not their NP. And so I have people coming to me like that. They're working as an NP, maybe in primary care or family practice. They're seeing way too many patients per day. And after X amount of years, they're like, maybe I'll go use my RN license and take utilization review from Marie. So I teach utilization review also. We teach, we have a diabetes course, diabetes health coaching.
So let's talk about your first, one of your first courses that I have here, utilization review. Can you talk a little bit more about what utilization review is? What might a typical day look like? And what are some tasks a nurse might do?
Mm-hmm. Utilization review and utilization management. They're nurses that usually work behind the scenes. They could be case managers where they're doing a lot of the case management, such as talking to the patients in between from the doctor's office, or talking to patients that have been injured, those kind of things. Talking to patients that are being discharged from the hospital, but also utilization review people. They work behind the scenes to determine or help to determine, who needs a certain surgery. Well, the doctor determines you need the surgery, but then the utilization review or risk management person gets a bunch of cases together, and they get case files. And they have to look at these files. There might be 18 a day that they have to go through, and they have to make determinations on, does this person, like, say they need a certain drug, a special, high-tech IV drug, or maybe they need a knee surgery, or, whatever it may be. Is it a pre-authorization? Is it a pre-certification? What is this? So they have to look at the case. They have to determine if the case, I got a couple little notes here. They have to determine the risk of the case. They have to go into either the pre-certification, the authorizations, they have 24 hours to sometimes a 14-day turnaround for these types of cases that they have to look at. So many times you might only have a 24-hour turnaround. Other times you might have a case where you're working on it. You go back and forth with the doctor or the office, trying to get more information to determine, does this person's policy show that they have such and such available to them? So it's not always just, do they need this medicine, but does the policy cover it? And then you have to look to see if all the determinations are made in regards to, basic medical care. If someone is in a certain situation, do they need X, Y, and Z? Do they require the knee surgery inpatient, overnight? Can they do outpatient? Has the physician done X, Y, and Z to determine that, yes, now we're ready, for this type of surgery or this type of medication or procedure? So that's what a utilization review nurse does. They work behind the scenes, but some of them can also work with the patients. It depends. There's so many different areas. There's concurrent review, there's retrospective review, there's prior authorizations, there's pre-certifications. I mean, there's just a huge area. So nurses will say to me, I want a job where I don't have to speak to anybody. And I'm like, well, utilization review, sometimes you might not speak to anyone. Other times you might speak 50% of the day to the doctor's offices and 50% behind the scenes. It depends on what kind of utilization review they get into. So, I mean, I could go on and on about utilization review, but it's basically not talking much to the patients, working behind the scenes.
So are there certain specialties that are best suited for utilization review?
Not really. Everybody needs risk management and utilization review. Every specialty and non-specialty. Now, the specialties that pay the most, which is shocking, but like I can take an LPN that's done home health, or they've done long-term care, rehabilitation, maybe doctor's office or hospital. RN, they could be an OR nurse, they could be med surg, they could be home health, they could be long-term care, I mean, whatever. But the specialties that are in the most demand, psych and behavioral health for utilization review, and they pay the most. And that is because not enough psych and behavioral health nurses want to work behind the scenes doing utilization review. Because if you get into psych and behavioral health, you're going to be a talker. You're going to be with your patients. So I have a lot of psych and behavioral health nurses that love taking the utilization review course from me. They learn the basics, and many companies will say they want 1 year or 2 years experience in utilization review, but with my course, they usually count it as towards 1 year experience already taking my course. A lot of companies. And then there's other companies that might say they prefer you have utilization review experience, but they don't require it. The other specialty that we don't get enough of is oncology nurses. We just don't. I mean, there's so much utilization review for oncology nurses, transplant nurses, and the kidney transplant or like bone marrow transplant, people like that, transplant nurses. Now, many times people that are operating room nurses come to me and they take my courses and they get a job in utilization review when their whole career was operating room, or OR circulating, and we can get them and help them to get into different types of utilization review or case management. Our OB nurses, I have lots of OB and NICU that come to me, and I'll say, look, I can help you, but you are in a very specialized area of maternal health and OB. So about maybe 30% of the jobs will accept you, either for OB and ICU, or they might train you in, like we teach a lot of medical, surgical, and orthopedic utilization review. So they might actually put you in that area since you had some of that training, even though your OB. So it's I mean, we can help almost anyone get into this, but of course, some of the nurses are going to have more opportunities than others depending on what their clinical background is.
Sure. That's encouraging to hear that it's overall helping most
Yeah,
specialties and that people
yeah.
aren't
I
like
mean,
access
really,
for it.
everybody gets sick and needs a service.
Yeah.
So, they could be just a little bit sick or very, very seriously acutely ill with specialized, problems.
Yeah. So let's touch on your course on data abstraction.
Hmm.
Um,
Yeah, that's HEDIS
yeah,
data
he does.
abstraction, right?
Thank you.
Well,
Uh,
HEDIS is really neat because you're working behind the scenes. I tell nurses, do you remember that book, I Spy with My Little Eye? You're looking in the book, I Spy with My Little Eye, and then you're like a magnifying glass or a banana, and you have to find in all the pictures where the hidden banana is. That's kind of HEDIS. Your I Spy with My Little Eye, and you're trying to see, have they had a bone scan? Women at a certain age are offered a bone scan as a baseline. And HEDIS is part of preventative health care, preventative health measures. So a colonoscopy, did they have a colonoscopy? And when did they have it? And were there polyps? If there were polyps, then they should be offered a colonoscopy every 5 years. There's different parameters for preventative health measures. And that's some of what HEDIS covers. HEDIS is to make sure that every person in this country gets the same preventative measures and same healthcare offered to them, whether they're rich or poor, whether they're on welfare or they're on the fanciest insurance. So the HEDIS measures go into all of those types of preventative healthcare. HEDIS is so important, even if you never do it. So HEDIS is I Spy My Little Eye, trying to go into records, pulling out data that Medicare is asking for so that they can determine how a doctor or a facility is doing with offering the HEDIS suggested requirements for humans, depending on what age. It's really interesting because if you know HEDIS and you do case management, care management, even telephonic triage, utilization review, if you understand HEDIS, you understand how medicine is here in the USA at this day and time, and how healthcare works and what is required for every person. Usually these measures come through your primary care, internal medicine, and family practice doctor.
Fascinating. So for people that go through your course, who hires those nurses? Like where would they get those jobs?
HEDIS?
Yeah.
Um, well, see, a lot of the case managers, care coordinators, nurse navigators. See, part of my chronic care management course, HEDIS is in it. They get it automatically.
Oh.
Yeah. And I don't sell HEDIS separately like some people do. And that's because I feel that if you're in case and care management, you need to understand HEDIS.
Okay.
So they go through the HEDIS course. Some of them actually get HEDIS jobs where you only do data abstraction, and you also do a little case management where you call the patients and talk to them about, getting them in for that colonoscopy or, whatever it may be, getting the kids in for whatever immunizations or whale child checks were missed. So HEDIS can be a seasonal job. It runs usually from January to May. That's when we do all the abstracting of the data out of the charts that the doctors worked on for a year. And we pull all the information for that. Like right now, my HEDIS nurses are working, say the ones for United Healthcare Optum. I've been helping them fill jobs for 5 years with my nurses. Thousands of them work for many of the big companies, probably like 4,000 just doing HEDIS. And they are 2025 right now, they are going to be pulling data from 2024 So they're looking for all the different measures that Medicare wants, and they're going to pick on different charts and just pull out information periodically, depending on what chart. It's like audits. And they're going to try to make a picture to show if the people are getting the basics of what they need, if it's being offered to them. So who hires a HEDIS nurse? Everybody hires a HEDIS nurse January through May. And then we also have HEDIS nurses that work year round, all year round. Those are the ones that just don't do the abstraction where they're pulling the data and they're helping with the reports, but they're actually throughout the year calling the patients, talking to the doctors, and trying to get people to it's called gaps, to fill the gaps in care so that they will have a good HEDIS report card the following year. I call HEDIS, it's like a report card. So, I mean, I'm really simplifying it, but I kind of talk in common sense.
No,
So
this
HEDIS is like a report card.
Yeah.
And
I've never heard of that.
So there are like 10-20% of nurses will work a HEDIS job year round. Then the other percent, like say 70%, 75%, whatever, 80% or whatever, they work HEDIS just seasonal. Okay. And you can work HEDIS seasonal part-time, afternoon, evening, weekends, or you can work it full-time.
That sounds so flexible. Yeah, so helpful for nurses to pick up that extra work.
Yeah, yeah. And then HEDIS, if you know HEDIS, you never really want to do it. You don't want to do that data abstraction stuff. You're not into that. If you learn it and it's on your resume, which it is with my nurses and my resumes, the employer sees, oh, wow, you took the care case management, transitional care man. Oh, HEDIS, the most updated measures, because we update the measures every year, make all the changes. All the update, oh, that's great that HEDIS. They are so impressed because they know that how the world goes round. How everyone is supposed to have a primary care, family medicine, or internal medicine doctor. That doesn't happen. Many people use the urgent care or the emergency room for their doctors. Some of the reason why is because the Medicare patients can't even get in with a doctor because the doctors are so full, they're not taking any more Medicare patients. But that's how it's supposed to work. They're all supposed to have one of those doctors, and then those doctors refer them to their cardiac or, their different specialists. And HEDIS is just a great way of trying to help people have a decent quality of life, and if they can't be healthy, maybe stabilize them.
Making sure that no one slips through the cracks. I feel so illuminated that I didn't know what that was. So thank you for sharing that.
Yeah, HEDIS is important.
Yeah, no, absolutely. Can we talk about your diabetes health coaching course as well?
Yeah. We just got our diabetes course approved for 8 continuing education credits. It's the second part is all nutritional. The first top part is 100%, diabetes and how to coach your patient. So we teach that program. Then we teach other programs so they can get into diabetes health coaching, wellness coaching, but not following the federal program that she has, because that's very focused with A1C. So then we have other ways of teaching in there where they have a little more variety and they can get into nutrition and all kinds of other little goodies. So that is for RNs, LPNs, and also if someone is a health coach, they can take that course, or a non-nurse. We have 2 different diplomas. If they're a non-nurse, they don't get one that says nurse, a certificate of completion. And then the nurses have a different certificate. So it's a great program for nurses. We've geared it to nurses, but every once in a while we change up some of the, when I talk, to say, okay, I know you're not a nurse, so you're not going to really understand this and medicines and this and that, but you should be aware of what your patients are on and have some general idea, especially because if you're a health coach, you're usually working with the doctor too at some point. All my programs will work at your own pace, but we all have every course has a special group, a Facebook private group that we expect you to come into and visit quite often, once a week, once a day.
Community building is so important for nurses. I especially think that for nurses that are leaving the bedside, because the bedside is such a community. If you are
Mhm.
arguing with your coworkers
Yeah,
at the bedside or supporting your coworkers at the
right.
bedside,
You
it's
still got so many
definitely a
community.
niche community.
Right.
So it's
Oh,
awesome to
and
hear.
a lot of nurses will say, am I going to be lonely working from home? Well, no, because you have a team. They're on video for you, or they're by the phone or whatever. Now, if you do HEDIS, where you're not talking to the patients, you're just working behind the scenes, tallying up the numbers, or you do utilization review, where you never really talk to the patients or the doctor's office, you're tallying numbers, you're behind the scenes. Some of those nurses, usually when they take those jobs, they're thrilled because they don't want to talk to anybody anymore. They're burnt out, or they'd be like, I love people, but I'm sick of it. But sometimes some people take those jobs because they see, oh, the pay was good. And oh, Marie, see, I show them all these different jobs that they can get. I like right now, I have a contact with CBS, and she's pushing all my nurses through to, get them past the scanning system and into the hands of a manager or recruiter. So we have all these jobs, and I have many connections, and I don't always have, connections all the time, but when I do, I have all these connections, and they're like, oh, I think I'm going to take that. Marie says, great company, this and that. Then they get into it and they're like, oh, so I'm not interacting with patients at all. I'm making this great money, but I'm lonely because I want to talk to my patients again. So sometimes a nurse might take a job where they're totally away from the interaction with the patient's family, the doctors, and they miss that. So sometimes, if you hear somebody is really unhappy, sometimes it's just they took a job that maybe wasn't right for them. And, then they go into maybe something else. I have some, they go into maybe case management or care coordinator. I do want to say, LPNs that are listening, I would say 30% of remote work jobs will go to you. That's it, 30%. The rest are going to go to RNs. So I always tell my LPNs, sometimes we'll have a lot of opportunities for you all at once. Other times it'll be a little quiet here and there, because yes, 70% of the jobs are going to go to RNs. They want RNs, various reasons. So it's not the LPNs can't get a job. They do. But sometimes they have to work a little harder to get those applications in. And like with Humana, I had like 500 or 600 nurses that got in, LPNs that got in with Humana almost 2 years ago. Well, that's the last time LPNs were hired much with Humana, and they all got in as like case managers, but they're under an RN. They're not associate case managers, but they're in like a pod. They'll have a couple RNs, and then they'll have a bunch of LPNs as case managers with Humana. Well, Humana hasn't hired LPNs much, here and there, but in the past 2 years. Why? Because those LPNs that got in are not moving. Can I say one more thing about the
Of course.
RNs?
Yeah.
This is a big one that comes up. You don't have to be a BSN to work from home. So I'd say 80% of the jobs will take an ASN, associate's degree nurse, or even a diploma RN. So BSNs, sure, there are some jobs here and there. Like out of 10 jobs, there might be 2 that will say you must be a BSN. 2. The others might say we prefer a BSN. Preferred means nothing. I tell my nurses not to even look at the preferred section of the job. When the job says, what do you need, for this job? What's the required? Preferred, ignore it. So many times the ASNs will be like, oh, but it says BSN. I said, no. Lots of times it just says preferred.
Yeah, that's huge. I actually started with my ASN. And it was my hardest degree to get from my bachelor's or my master's was my associates. They
Mhm.
jam-packed that degree.
Yeah,
So,
yeah,
yeah, I'm a huge
not
proponent
easy.
for associate's degrees, especially if it helps you get your foot through the door as a nurse and you can climb up or just stay where you are.
Mhm.
So if there's not a like degree requirement, is there a certain amount of time that you need to work at the bedside for?
That was perfect. Thank you. Yes. Well, we tell the nurses that they have to have been a nurse at least 1 year, and they need patient facing or bedside experience. So what patient facing is, maybe they worked in a doctor's office, bedside just means bedside. The word bedside means, did you touch your patient? That's what it really means. When we say bedside experience, it doesn't mean you had to be in the hospital at the bedside. But I mean, if you were in the hospital at the bedside, that's great. We say 1 year bedside or patient facing experience. Now, sure, if you have 2 or more years, it's better before, to get into these remote jobs. I don't usually let anyone take my course unless they've had 1 year of bedside and patient facing experience in the USA. And so, yeah, many of the nurses will say, well, why does it say, oh, you need 3 or more years? And I said, well, some companies will say they want 3 or more years. Some will say 2. And once in a while, they'll say 1, or they don't say anything. They just, leave it open.
Yeah, thank you for clarifying. So, Marie, we unfortunately have to wrap this up,
Oh,
which is a bummer because I feel like I could go on for so long. So, thank you so much for taking the
mhm.
time out of your day and
You're
really breaking
welcome.
thing down on such a basic
Mhm.
understanding level. Thank
Can I
you.
say one more thing
Of
about the
course.
years of experience? The, Many people will say, well, why do I have to have, 1 year or more, or 2 years or more, whatever? It's because of malpractice. When you are a nurse and you are remote from home, even though you have a team you can call and they're on video or whatever, and you're not really alone, but you are alone. It's a matter of the hospitals, the facilities, they have to pay malpractice insurance on everyone. And the companies, these insurance companies, are not going to let them hire you if you haven't had any bedside experience. Because I mean, really, you need more than a year to have decent theory and really do the 360 degree, hands-on, and you learn from other nurses as you work with them. But yeah, it's malpractice reasons. They say, no, that person, I don't care, if they were a nurse's aide for a million years, they have not worked 1 year at the bedside.
Yeah,
So
they
they
don't know
won't
the
they won't
role.
hire you.
Yeah. Thank you. I had no idea on that either.
Yeah.
Great inside tip to leave us with.
Well, thank you for having me. I appreciate it. And
Absolutely. All right. This has been your Nursing Minute. Thank you so much.